Welcome, everybody. Welcome to our webinar on leading the way for inclusion, disability and rehabilitation post-COVID-19, hosted by Learning, Acting, and Building for Rehabilitation in Health Systems. My name is Rosemary Morgan, and I am based at Johns Hopkins Bloomberg School of Public Health in Baltimore, Maryland, in the United States. I'm currently sitting in my office, but you can't see that because I have a virtual background that is from ReLAB-HS, that is blue with a colored circle logo for ReLAB-HS that is purple and yellow and blue behind me. And I have glasses and a black sweater on today. So we are here today because of what is happening tomorrow, which is the International Day of Persons with Disabilities. The theme of this day is around leadership and participation of persons with disabilities towards an inclusive, accessible, and sustainable post-COVID-19. So we know that people who live with disabilities are among the most affected populations amid the pandemic, and where marginalization, discrimination, vulnerability, and exploitation are everyday factors for many people, the increased risk of poor outcomes have been magnified with the reduced access to routine healthcare and rehabilitation services, more pronounced social isolation, poorly tailored public health messaging, inadequately constructed mental health services, and a lack of emergency preparedness for people with special needs. So ReLAB-HS joins others in calling on domestic and international public health officials, political representatives, advocates, supporters, and every citizen in every community to learn from the experiences of people living with disabilities during the pandemic and push for more meaningful investments, which will reduce the barriers faced by people with disabilities in every community on Earth. But before we begin our webinar today, a little bit of housekeeping. So this event is being recorded and will be available on the ReLAB-HS website. So we will have time for questions. So please, if you have any questions, do type them into the Q&A function. You will find that at the bottom of your screen. If possible, please do state your name and affiliation ahead of your question and your location. We are very keen to hear from people from a variety of locations. You are able to post questions anonymously if you wish. Please do try to keep your questions brief so we can get to as many as possible, and do not worry about spelling. The act of contributing is valued much more highly than the art of spelling. Live closed captioning is available. You turn this on by clicking closed caption button or the CC button at the bottom of your screen. You can turn on subtitles or the live transcript. Please do email us with any follow-up questions or points, and do follow us on Twitter at ReLAB-HS. And if you're tweeting during the event today, please do make sure to tag us. So what is the aim of ReLAB-HS? Well, we are a consortium, and we aim to contribute to global efforts to strengthen rehabilitation in health systems and support the development of health systems that are inclusive of rehabilitation care, including assistive technology. Our long-term goals are to improve the health and well-being of the population and provide downstream benefits in terms of future healthcare costs, increased productivity, and social inclusion. We are a consortium of organizations with expertise in health systems, implementation science, workforce development, and service delivery innovations. You can see here on the screen. The partnership includes the Johns Hopkins Bloomberg School of Public Health and International Injury Research Unit, Nossel Institute for Global Health at the University of Melbourne, Humanity and Inclusion, Miracle Feet, Momentum Wheels for Humanity, and Physiopedia. In part of ReLAB-HS, we are integrating a GESI approach, and GESI stands for Gender Equality and Social Inclusion. So our inclusive development approach is really grounded in the GESI principles, and while emphasizing intersectional disability inclusion. We are committed to an inclusive development approach that leads by example, actively including and benefiting from the knowledge and experience of diverse individuals and their representative groups. And this approach is central to the work that we are doing. So before we begin our main event, a little bit of context. Today we are here for tomorrow, which is the International Day of Persons with Disabilities, and 1 billion people, or 15% of the world's population, experience some form of disability. Persons with disabilities on average as a group are more likely to experience adverse socioeconomic outcomes than persons without disabilities. And we saw that, during COVID-19, this has only been exacerbated. In many low-income countries, persons with disabilities face discrimination and exclusion from school, decent work, healthcare, other services, and are more likely to have unmet health needs, but are less likely to have the access to services to meet those needs. So what about disability and rehabilitation? Well, in some low and middle income countries, barriers for persons with disabilities are so significant excuse me, that only 3 to 5% are able to access the rehabilitation services they need. They are 2 times more likely to find healthcare providers' skills and facilities inadequate, 3 times more likely to be denied healthcare, 4 times more likely to be treated badly in healthcare facilities. And when disability and gender or other social identifiers intersect, some individuals might be disproportionately affected and face additional barriers. And women and girls with disabilities constitute at least 19% of the world's female population. And the literacy rate for women with disabilities is as low as 1% in some part of the world. So let's now move on to our main event. Here are our 4 speakers today. We have Lillian Asiimwe, who's a Gender Equality and Social Inclusion Officer in ReLAB-HS in Uganda and is part of Momentum Wheels for Humanity. Lillian, please do go ahead and introduce yourself.
Thank you, Rosemary. My name is Lillian and I am from Uganda. I live in Kampala in a place called Gayaza on the northeast part of Kampala, approximately 20 meters away from the city center and maybe 50 kilometers away from the airport. Today I'm wearing a light pink top and hot pink pants. I'm glad to be here. Thank you, Rosemary.
Thank you, Lillian. And next we have Diana. I'm sorry, Diana, I'm going to get your last name incorrect, I believe. So I'm gonna have you to repronounce it for us. Shishir bin Ina, who's a Gender Equality and Social Inclusion Officer from Ukraine and is also part of Momentum Wheels for Humanity. Diana, the floor is yours.
Thank you very much, Rosemary. Hi, everyone. My name is Diana Sherbinina, and it's a great pleasure to participate at the webinar dedicated to the International Day of People with Disabilities. I'm Project Support and Inclusion Officer at Momentum Wheels for Humanity. I have work experience in such sectors as NGO, governmental, and private. Before, my work has been dedicated more to business relationship strengthening, and now I am delighted to be engaged in the strengthening of the medical system in Ukraine. I'm currently at my home office. You cannot see it now because I have the blue background with a circle on it and 2 logos, ReLAB-HS and USAID. I am located in the suburbs of Kyiv. And I'm wearing now a black sweater and a gray jacket on me. Thank you.
Thank you, Diana. And next we have Mohammed Iqbal, who is the Gender Equality and Social Inclusion Officer for ReLAB-HS in Pakistan and who is part of Humanity and Inclusion. Mohammed, over to you.
Thank you very much, Rosemary. Hello, everyone. My name is Mohammed Iqbal. I'm working as Rosemary mentioned, a disability gender needs specialist and with the Humanity and Inclusion. I'm based in Islamabad, working as a person with a disability, and I wear a black jacket and black shirt. I'm looking forward to speak in this fantastic event. Thank you.
Thank you, Mohammed. And our discussant today, who will be coming on after our main Q&A session, is Abdul Bachani, who's the Program Director for ReLAB-HS. Abdul, please do go ahead and introduce yourself.
Thank you, Rosemary, and hello, everyone. Really great to be here and great to have this webinar in preparation for tomorrow's big day. My name is Abdul Bachani. As Rosemary mentioned, I'm the program director for ReLAB-HS, serve as associate professor at the Johns Hopkins Bloomberg School of Public Health and director for the Johns Hopkins International Injury Research Unit. I'm from Kenya originally, currently based in Baltimore at Johns Hopkins. I'm participating in this webinar from my home office. I have the same blue background as every one of the other speakers and wearing a sweater with navy blue and gray stripes. Great to be here.
Thank you, Abdul. So without further ado, let's move on to our main part of today's webinar, which is the Q&A session. So I am going to stop sharing my screen. So our first question today is for all our panelists. And the question is, what is disability and inclusion look like in your country? And how has COVID-19 impacted this? So Lillian, I think let's hand it over to you to start us off.
Thank you very much, Rosemary. In Uganda, disabilities vary from moderate to severe and multiple. A provision of rehabilitation services at all levels is clearly stated in the Health Systems ministerial policy. The Ministry of Health has a division directly charged with regulation of rehabilitation and AT services. Uganda has a comprehensive body of legislation that upholds disability rights, particularly through affirmative action, where we see the STARS concept note draft review ongoing. STARS, for your information, is the systematic assessment for rehabilitation situation. The government's commitment to disability compared to other cross-cutting issues like gender remain low in terms of implementation. Ministry of Gender, Labor and Social Development provided funding to the district level government for community-based rehabilitation programs, which is no longer functional as of today. When we look at inclusion, there's been persistent discrimination against persons with disabilities, especially albinism, intellectual or psychosocial disabilities, which again limits their accessibility to resources like healthcare, education, employment, the physical environment, and information and communication. The National Disability Inclusive Planning Guidelines for Uganda of 2017 provides recommendations for potential interventions on rehabilitation and assistive technology to ministries, including Ministry of Education and Sports, Ministry of Health, Ministry of Works and Transport, and Ministry of Veterans Affairs. Though there is a policy for free healthcare access by all Ugandans as of 2001, people with disabilities require therapies that are not provided in health facilities. Healthcare delivery is not structured to provide patient-centered care for people with disabilities, and limited physical accessibility of health facilities, especially for people with disabilities, exists. Health facilities infrastructure is old. You will find no special beds in labor rooms for women with disabilities here in Uganda. And health workers have continued to express their inadequate experience in understanding of patients' history, mostly the deaf, hard of hearing, deaf and blind, those with challenges in speech, and mental illnesses. People with disabilities are inadequately reached with healthcare messages. The Ministry of Education and Sports has a Department of Special Needs and Inclusive Education, but it is unclear if there is a budget that takes care of the assistive devices required for education purposes. There are 113 special needs education schools across the country, but not in all districts of Uganda. According to Inclusive Education Uganda 2017 survey, children with disabilities are particularly disadvantaged by non-inclusive teaching methods, inflexible curricula, and examination systems. Most schools are not inclusive. They have not reduced barriers for all children to access, participate, and achieve in education. There are barriers to movement and communication in the physical environment, prevent people with disabilities from enjoying the same rights, privileges, and opportunities as other members of the society. For example, a child may have access to a wheelchair and manages to access school, but still faces challenges with the physical environment where there are no ramps, the ground is not leveled, and there is limited space in the classroom for their wheels. Thank you, Rosemary.
Thank you so much, Lillian, for that really comprehensive background about, what does disability and inclusion look like in Uganda. I will come back to you about with the COVID-19 question to get a little bit more detail about how COVID-19 has impacted this. So let's turn to Ukraine now, and Diana. So what does disability and inclusion look like in your country, and how has COVID-19 impacted this?
Thank you very much, Rosemary, for the question. So today in Ukraine, the assessment of the loss of functioning of citizens is carried out mainly based on outdated national standards. There is a lack of public policies and measures to protect people's rights, including barriers to inclusive education, healthcare, employment, housing, and participation in political and public life. Persons with disabilities in rural areas consistently face barriers to accessing healthcare and rehabilitation services, as well as many children with disabilities are institutionalized in settings that lack of the same rehabilitation services. Decision makers and citizens tend to have limited awareness about the right to a barrier-free space. Accessibility in the built and digital environment in Ukraine is lacking, influencing the exclusion of persons with disabilities and other marginalized groups. Additionally, there is a lack of adaptation of information, sites, and applications for all citizens, and the introduction of digital technologies in public and social services has not always been accompanied by digital skills training. According to the statistics, 2.7 million people have been registered in Ukraine as people with disabilities. Now I'd like to open up some subtopics and talk first of all about early interventions. People with disabilities keep a thorny path in Ukraine because of the lack of early intervention services. The Ministry of Social Policy, together with the Ministry of Health, Ministry of Education, and international and public organizations, will develop a bill. It's called on early intervention, which in particular will determine the algorithm for providing early intervention services. Meantime, medical workers suggest parents to leave their children in maternity hospitals, as according to the law of Ukraine, if it is identified that the child has a mental or physical disorders, parents may refuse from it. In most cases, parents may be not even aware of early intervention services. After refusals, the children are driven to special institutions instead of getting an opportunity to stay with their family, having higher chances to become socially readjusted. Let's talk about education. Only approximately 6% of educational establishments are inclusive in Ukraine. What are the challenges? Lack of absence of social and psychological support. Buildings and transportation systems are not adapted to the needs of people with disabilities. Also, there is a lack of adopted materials. What about employment? Only 16% of people with disabilities are employed in Ukraine. The challenges are as following: lack of social support to create more inclusive workspaces and jobs, People with disabilities had previously challenges with education, as I already mentioned. Also, we are talking about lack of inclusive transportation and infrastructure in Ukraine, and no equipped workplaces. State services. It's hard to get services when people cannot use transportation or even leave their houses or apartments. According to the statistics, 2/3 of respondents have inconveniences using public transportation. COVID-19 has badly influenced on the client's access to rehabilitation services, especially for patients in the acute period, as some rehabilitation units in hospitals and clinics have been adopted to accept COVID patients. It means rehabilitation patients should look for alternatives. Additional traveling can cause catching of COVID-19 and its modification, and these modifications already, and these people are at high risk. Plus, as it was mentioned before, transportation and infrastructure system in Ukraine have lower level of adoption for people with disabilities. During quarantine, educational establishments are closed from time to time, and children need to stay at home and study there. And especially for children with disabilities, it's extremely challenging to study at home. Also, the priorities of the Ministry of Health of Ukraine have been shifted to COVID issues, and other spheres fall out of sight to some extent, including rehabilitation sphere. Thank you very much, Rosemary. That's it from my side.
Thanks, Diana. And Mohammed, can you please tell us what disability and inclusion looks like in Pakistan, and how has COVID-19 impacted this?
Thank you very much, Rosemary, for such a great question. So when you look at Pakistan, for example, the persons with disabilities are unseen, uncounted, and unheard population to the great extent. Unseen because, for example, in most of the development initiatives, in government initiatives, persons with disabilities are largely ignored, and unheard because their voices are not coming to the development agenda, to the government agenda. And uncounted that, for example, a lot of inequalities can be observed when it comes to the data procedures. Therefore, when you see and when you look at to the government and the other stakeholders, we see less efforts but greater variation in the data. For instance, in the 1998 census, the percentage of persons with disabilities in Pakistan was 2.49% of the whole population. In 2017, after the 20 years, this ratio is come down to 0.848%, which clearly demarcate between that how persons with disabilities are counted. It's a methodological, or you can say, problem, or the way you ask question about the disability. And when you look at to the Pakistan Poverty Alleviation Fund, using the Washington group of question, the prevalence rate that they have shown is 12% of the whole population. Now, it is really a difficult situation for persons with disabilities and for the country like Pakistan, whose 63% of the population is living within the rural areas. When we talk about the rural areas, which means that these people are subject to greater barriers and limited access to the support services or limited social services. They have a number of challenges in transportation, accessibility, both physical and digital, mobility, and stigma, marginalization, and many other attitudinal, environmental, and institutional barriers. Now, in response to the situation of marginalization of persons with disabilities, some effort has also taken place. For instance, the first one is after the 18th Amendment of the Constitution of 1973, right-based provincial legislation of persons with disabilities are introduced. In Sindh, province, the empowerment of persons with disability department is created to ensure the care and protection of the rights of persons with disabilities. And then the rest of the country, the same function is performed by the social welfare and special education and women empowerment to care of persons with disabilities. Along with this, a large network of organization of persons with disabilities and international organizations are working for the welfare of persons with disabilities. However, there is no national federation for the persons with disabilities, which make the disability movement more scattered, or you might have seen that people are, associated with the different chapters, but not coming into the universal agenda. When we talk about the COVID-19, so the first thing is the impact on the inclusion of persons with disability is the personal assistant is detached, due to which the support services are limited for persons with disabilities because most of the person need 24/7 the personal assistant. Unavailability of accessible information. This include the COVID-19 messages, vaccination, and precautionary measures. This is not available, and that's why persons with disabilities don't know what to do and how to move and where to contact in the specific situation. It increases the unemployment rate and as well as the limited access to social protection, which has impacted the income security for persons with disabilities. And most of the persons with disabilities said their persons with disabilities are left behind. Persons with disabilities are also having challenges in the online means of education because they cannot adopt it according to their needs. Health and rehabilitation is also impacted a lot because the persons with disabilities are not prioritized in the health situation due to the overload of the COVID-19. Thank you, Rosemary.
Thank you, Mohammed, for that great summary. So, Diana, I want to go back to you now. Could you tell us a little bit more about the relationship between disability and rehabilitation?
Thank you very much, Rosemary, for the question. So Ukraine is currently reforming its health system with rehabilitation evolving towards contemporary understanding and approaches to rehabilitation. Still, the level of development of rehabilitation and habilitation services in Ukraine is very low. Outdated approaches to prevention, treatment, and rehabilitation are not aimed to increase the physical activity of people with disabilities, elderly people, young people, and children. To qualify for a state-funded assistive product, a person needs to be registered as disabled. People who don't have a disability status cannot use state social packages to get assistive technologies and rehabilitation services. And in average, it takes 4 up to 6 months to get a disability status and a group of disability after a disease or trauma. And this process includes preparing of a large number of documents and going through a complicated bureaucratic system. All this time while a person is waiting for obtaining a disability status and a group, they can purchase assistive technologies and do rehabilitation for their own money, but this sum won't be reimbursed after they will get disability status. And we all know that rehabilitation in the acute period is extremely important for the general health conditions and recovery ability. That's it from my side, Rosemary. Thank you.
Thanks, Diana. Yeah, I think it clearly shows the importance of the relationship between the rehabilitation for persons with disabilities. Lillian, I'd like to go to you next. Are persons who identify and those who do not identify as having a disability currently receiving the rehabilitation services they need in Uganda? And how has COVID-19 impacted their access to rehabilitation services?
Thank you, Rosemary, for the question. There are many rehabilitation centers in Uganda, but they are not equally geographically distributed. Majority depend on donor support, while others are private and their services are expensive. Access to rehabilitation services is based on the type of disability, the geographical location, and education level. The Uganda Functional Disability Survey indicates that 62% of people with disabilities who need assistive technology services don't have access to the devices. And only 2% of children and adults with sight difficulties use eyeglasses or contact lenses. So there's the unmet need for both is really high. When we look at COVID-19, persons with disabilities faced a number of challenges during this time. That includes limited access to information on COVID-19 itself, food, healthcare, and there was limitation for accessibility of transport given the ban on transportation, especially in the first March 2020 lockdown. We see that parents of children with disabilities could not even access the information sent by Ministry of Education. They had challenges helping children with intellectual disabilities, helping them to study, the fact that they could not manage behavior for such children with disabilities. People with disabilities also who depend on other persons for help with transportation or language interpretation face challenges because they had to pay twice, given that they are moving with a second person for help. Transport charges were increased, so the burden was very heavy on people with disabilities. We see others that missed their appointments and reviews in the health clinics due to the ban on transportation. So that's it from me, Rosemary. Thank you.
Thanks, Lillian. And Mohammed, why is it important to ensure participation of persons with disabilities and their inclusion in leadership in the context of rehabilitation, and how can we improve this?
Thank you very much, Rosemary. If we see that, for example, about the situation of persons with disabilities, we often observe that persons with disabilities have limited choice in control when they are using the assistive devices in rehabilitation. And therefore, for example, they go to the hospital, they go to the different institution, depend upon the circumstances and depend upon the local authorities that how they are providing, but they are designing the programs for that, and that without asking them. That's the creation, which is basically presenting the gap between the service provider and the people who are using it. This situation actually multiply, you can say, the vulnerability for persons with disabilities in various contexts. And that, for example, I will share that when someone is providing the wheelchair to a person with disabilities, though it is a customized according to their needs, but it's also very important to consider that how that wheelchair is basically perceived in that particular community, how that wheelchair is perceived by the person, whether it is the only choice for that particular person. Is it accepted by him, by his basically his mind, or is it basically according to the self-autonomy of persons with disabilities or not? So this is really important. It's also when there's a gap, for example, you're providing the services, but there is, for example, we didn't listen from the users. It provide a partial image to the policy makers and practitioners to understand what is the impact of that particular devices on the person. specifically on the person who is coming to the education, who is going for the employment and different other things. So it's really very difficult for all of the practitioners and policymakers to understand what is the impact coming from that. Now, to ensure the inclusion of persons with disability and full participation, what we need to do. Consider that persons with disabilities are a heterogeneous group with the diverse needs. And diverse need, for example, it doesn't mean that all the polio, people affected from the polio is using the wheelchair. We do not say that, for example, every blind person, every visually impaired person must use the white cane because they have the visual impairment. We need to understand that, for example, that particular person might be completely dependent upon the mental mapping that they are doing, or any other assistive devices. Involve persons with disabilities and their representative organization in planning, in designing, when we are planning and design for the rehabilitation of persons with disabilities. And also in the implementation, in monitoring and evaluation about the rehabilitation services to see that what works for them in the particular circumstances. We understand according to the time, to the society, to the different individual characteristics, the needs of persons with disabilities are varied. It is already identified by the Convention on the Rights of Persons with Disabilities that the persons with disabilities have their individual characteristics, which is actually on the topmost priority in ensuring the Convention on the Rights of Persons with Disabilities in the different countries. We should also involve persons with disabilities in the reforms. When we do policy changes in the rehabilitation and assistive devices, we need to do that. What reforms should be made, in that heterogeneous group should be involved to understand what has done and what is need to be done. Also, we need to build agenda of the rehabilitation on the principle of the people, by the people, and for the people, so that we can understand that the most of the ownership is for those who are using the rehabilitation services. And that particular thing will give us the self-autonomy, the choice in control for persons with disabilities and their representative organization as the agent of change, as the agent of society. Thank you very much, Rosemary.
Thank you, Mohammed. Really, lots of great reflections and recommendations for moving forward there. So one final question for all our panelists, and I will ask that you keep your responses very brief to under a minute. What we would like to know is, what is the future direction of rehabilitation in your country? And Diana, let's start off with you.
Thank you, Rosemary, for this great question. So I would say here to share like into subtopics, like ideally, it's client-oriented sphere, clear and understandable mapping of services, easier to get disability status. I already mentioned digitalization of processes and digital awareness of people, more of IT and rehabilitation centers and IT workshops in Ukraine. More practical first steps could be done. It's strengthening of cooperation with responsible ministries and political will, strengthening of multidisciplinary rehabilitation teamwork. And everyone would like to know the project orientation in Ukraine, and I can name some of the points. So there's their planned rehabilitation in Ukraine, creation of journey mapping for IT hub, and implementation of best world practices in here in rehabilitation sphere. That's it from my side. Thank you.
Thanks, Diana.
I can tell more, but we don't have so much time.
Thank you so much. So that was great. Mohammed, what is the future direction of rehabilitation in Pakistan?
So in the first look, it was really held by the medical practitioners, and definitely that, for example, they dominated on that and the rehabilitation. But since the inception and the introduction of the projects like ReLAB-HS, it's now coming to the user friendly, and therefore, like for example, the person-centered approach is adopted, and also it's really timely because the introduction of the provincial right-based legislation is actually clubbing that particular aspect of the person-centered approach, which is really helpful. And I say that, for example, in future, we will be more inclusive, more adopted and resilient infrastructure for the rehabilitation in Pakistan. Thank you.
Thanks, Mohammed. And Lillian, what is the future direction of rehabilitation in Uganda?
Well, thank you very much, Rosemary. Fortunately, Uganda has a Persons with Disabilities Act of 2020 and defines assistive devices and mandates the government to provide them at no cost or at subsidized cost to persons with disabilities. It also mandates Ministry of Health and Ministry of Education and Sports to provide rehabilitation services to people with disabilities and provide assistive devices for inclusive education for persons with disabilities. I see umbrella organizations for persons with disabilities running awareness campaigns to promote their rights with the aim of reducing environmental barriers and increase their participation in the society. And of course, the ReLAB-HS activity implemented by Momentum Wheels for Humanity here in Uganda will strive to strengthen health systems and the workforce capacity for the provision and rehabilitation services across all levels of care in the regions of intervention. Thank you very much, Rosemary.
Thank you, Lillian. So I'd now like to turn it over to Abdul Bachani, who is our discussant for today, to give his reflections on the discussion and any sort of key issues and points moving forward. So Abdul, over to you.
Thank you, Rosemary, and many thanks to our panelists for that great discussion and highlighting many of the key issues that individuals with disability face in general when accessing health services, but in particular, the exacerbation of those challenges through this pandemic that we've all been living through. And I'll keep my comments brief in purpose because I see a number of good questions coming up and I want to make sure that we do have a chance to discuss some of those issues as well. But one of the common themes coming out here is, we all understand that the burden of disability is really high. However, one of the key issues behind addressing this issue of disability and addressing the needs of people living with disability is a measurement issue, as Mohammed mentioned. And that's, if we don't understand what the burden is, what the distribution of this burden is, it's hard to address that burden. So there's a data issue that's coming out here. But there's also this issue of lack of policies, lack of training and capacity, lack of social support systems that we've heard about, lack of infrastructure, health services not designed to accommodate, or health facilities not designed or planned to accommodate individuals with disability. So when it comes to rehabilitation, the focus for rehabilitation is aimed at improving functioning of individuals with disability, as well as other people who need rehabilitation services who may not be labeled as disabled. The label disability carries with it a lot of weight based on socio-cultural contexts, and that further stigmatizes individuals. But with the Learning, Acting, and Building for Rehabilitation in Health Systems activity that's funded by USAID, we're really aiming to take a systems approach to addressing this whole issue of enhancing availability and accessibility to rehabilitation services in more general, making sure that rehabilitation services, first and foremost, are considered core services within the health system. And when we talk about a systems approach, that means taking a holistic view and this notion that nothing falls outside the system. So training programs, the availability, accessibility of training programs, the context there matters, why training programs exist matters, and they may be driven by global, local, regional policies, prioritizations, et cetera, and that we need to understand. The other big thing here is, as we've heard from Lillian in Uganda, in many countries, some good policies do exist on the books, but implementation remains a challenge. And how do we translate technical know-how, policies, and regulatory environment to implementable programs that serve the needs of the population? And through taking a GESI approach, gender equality, social inclusion, a focus on individuals' disability and the most vulnerable people in our societies, I think if we design and address the needs of our systems and address the needs of the most vulnerable individuals in the population, we will naturally be strengthening these systems to address the needs of the whole population. So if we're working to make accessible health facilities for individuals with disability, making sure that equipment and specialized equipment is available and, those issues are prioritized, appropriate training is provided to healthcare providers, will naturally be strengthening their ability to provide better care to the rest of the population as well. And that's what really I want to stop at. A systems approach focusing on implementation, translating the technical know-how that we have into implementable programs is really where we need to go as a field. And when we'll work on strengthening systems to address the needs of the most vulnerable in our societies, we will naturally be strengthening systems for everyone in the population.
Great. Thank you so much, Abdul. So let's move on to our Q&A session now. We have just about 12 minutes to the end, so hopefully we can get a number of questions in. We've got some great questions already. So the first question I'd like to pose is from Amanda Egger, who's a Canadian physical therapist with Physiopedia. She asks, are there any stigmas associated with being labeled disabled in your country? What are the barriers or challenges associated with this possible label? Mohammed, maybe I will direct this question to you first.
Thank you, Rosemary. And yes, it's really historical. As Abdul mentioned, that's the 4-action model is used for that. First of all, some people are targeted on the basis of disability, using the stereotypical approaches. A person cannot do this or that. Then it create a practice for some people, and it's create the policies. And based on these policies, persons with disabilities prevent from the decent employment, education, and all those things. So the 4-step model applied to a lot of people. For example, women with disabilities who face triple discrimination because of womanhood, and also attached with the person is a woman with disabilities. The 2 stigma create the binding approach towards barrier, which create the more marginalization for persons with disabilities. Another is for the deaf blind people, is like, for example, that person cannot sense because he is a deaf and blind too at one time. Psychosocial disabilities are considered as the not normal bodies and associated with the terminology abnormal, which is really push them from the mainstream society. Deaf people, for example, when they're using the sign language, people are using just for the fun, and those are the some example which is really hurting persons with disabilities and pushing from the mainstreaming. Thank you.
Thank you, Mohammed. Lillian and Diana, would either of you like to come in with your thoughts related to your own contexts? Lillian, please.
Yes, please. Thank you, Rosemary. To respond to the same question, here in Uganda, we do have people that believe if someone has sex with a person of albinos, that is a disabled person, they will be healed from HIV. If a woman gives birth to a child with disabilities, that means it is their own wrongdoing. So they have been punished by God, and such women, you'll find them hiding their children and not letting them out. And those children will be stigmatized and discriminated, and they will suffer in silence inside their own homes, with their own families, in their own community. So it is huge here in Uganda. Thank you.
Thank you, Lillian.
Rosemary, from my side, I would also we have the same situation here, and it is historical one, as Mohammed said, as people with disabilities thought to be a burden for the society. That's not because of their disabilities, that's because of lack of our knowledge as a society, what are their direct needs. So this is like the first step we need to do, and also to gain our personal knowledge about people with disabilities. Thank you.
Thank you. So the next question comes from Valentina Pomato, and they asked, connectivity and digital technology have played a key role during lockdowns, with telemedicine and telerehabilitation gaining relevance and ground. Were these options in place in your countries? If so, what barriers are yet to be lifted, looking in particular at the situation of persons with disabilities to access tele-rehab? So Lillian, Mohammed, Diana, would any of you like to take a stab at this question from your context?
Yes, please. I have my mic mute. So yeah, concerning telerehabilitation, that's one of the points, and I already mentioned as the steps for the project to implement in Ukraine. But we do have some approaches and steps done in telemedicine. And the most challenging, maybe for a lot of countries, the same for Ukraine, is that first of all, people don't have devices to access to telemedicine, no laptops, no phones. Then the coverage of the internet is poor, especially in rural areas and in mountain areas. Also, these programs are done, for example, in Ukrainian on land, people from minorities, they cannot get access because they don't understand the information there. And also digital awareness and knowledge is very poor in Ukraine. I have my personal input in here. When I was in the queue in the hospital, I was trying to explain, we're trying to upload this app, eHealth, to the phone of a guy standing in the queue, and he's quite young. But this is not the problem, again, of here, not the problem of a person itself, but of the system and of Ukraine, because Minister of Health of Ukraine, Minister of Digitalization of Ukraine, and Education of Ukraine, they need to give this digital awareness and knowledge to people to understand how to use these services. That's it from my side. Thank you.
Thanks, Diana. I do want to move on to some of the other questions, and we have a similar question from Rita Crespo Fernandez and Annie Mazagobian about community-based rehabilitation. And Mohammed, I think I will direct this question to you. So Annie asks, is there a community-based rehabilitation network in your country? And if yes, what is the structure? Does it constitute if NGOs or government, is it part of the non-governmental organizations or government? And Rita asks, do you have examples that you can share of successful community-based initiatives on disability inclusive rehabilitation? So both questions focus on community-based rehabilitation. Are there networks? Are there examples of good initiatives?
Yeah, so in Pakistan, there's many networks of organizations of persons with disabilities and NGOs focusing upon the community-based rehabilitation. But when we look into the evidence of the community-based rehabilitation within the organizations of persons with disabilities, it's really rare in a sense that persons with disabilities are not identified even in that condition for the basic needs and in the grassroots level. And that's why, like, for example, when we are talking about the person-centered approach, clubbing that with the CBR is an important thing. And as Abdul mentioned, to look at, for example, the thing from the person window to the system view is amazing idea, but it's really, for example, not taking on the persons with disabilities. Yes, some projects is actually done and the rehabilitation of persons with disabilities using the CBR perspective. It was quite successful, but not actually build upon that. And that's the issue with the networks. They are going with the slogans of the time. They are going with the different slogans of the time, and sometimes it's really different because we are not building upon what we have done and predicting the future. So that's one of the issue with the CBR.
Thanks, Mohammed. Lillian, I'd like to pose the same question to you and your reflections from Uganda.
Sorry, Rosemary.
So the question is around the community-based rehabilitation in Uganda. Are there examples of successful initiatives? What is happening?
Currently in Uganda, community-based rehabilitation has been changed to community development initiative instead of CBR, and there's a lot that's going to change, but currently it is not in practice. Thank
you. Thanks, Lillian. We have one final question, and Abdul, this question is for you. It's from George Gotsatzi from Georgia. So the question is, to be individual patient-centric in the design of the package of rehabilitation services to be delivered under UHC, are there tools and methodologies developed by Johns Hopkins University or any other institution that could be used to A, evaluate needs, and B, tailor the service design to individual needs?
So thanks for that question. And yeah, so to take a patient-centered approach, we really do need to understand the needs of the patient. We need to understand, what health needs, accessibility needs, etc., and then tailor services to that. There are tools that are being developed by the World Health Organization on packages for rehabilitation interventions that will be released sometime over the next year. Those will be available. There's several assessments out there, some that Hopkins and other organizations, partner organizations within and outside the ReLAB-HS consortium have developed, tested, etc., that are available, and we'll be happy to link you to those. But essentially, that's basically what we're trying to do when we talk about a systems approach to rehabilitation, is to ensure that systems are designed as such that we're responding to the needs of individuals. And going back to the points that, for example, Mohammed raised with respect to community-based rehabilitation, and Lillian, your point about how the name has now changed for community-based rehabilitation to community development initiative, because while it was really conceptualized as something that was going to provide or make rehabilitation services accessible, the way the programs were eventually designed and implemented were more taking a development approach and community inclusion approach. What we really need to do is make sure that rehabilitation services are provided at the community level, look at the primary healthcare settings, lower level providers, community healthcare providers, and make sure that we have processes in place based on context utilizing technological innovations wherever we can to be able to identify what the needs are of individuals who need these services and then meet those needs. So rehabilitation services are not one size fits all. Rehabilitation is different for different health conditions, different individuals, different, I mean, we need to understand the individual and then customize a rehabilitation plan based on the individual. And that's what needs to be what needs to happen. There's guidelines that are out there that need to be customized, contextualized, and implemented. So these are some of the things that the ReLAB-HS program and others in the field of rehabilitation are going to be working on over the next few years, and we really all can contribute to that as a wider community.
Thank you so much. I also wanted to thank, I saw in the chat box, the other attendees wouldn't have been able to see it, but we had some great comments from Sally Newton and Sarah Magoba. Sally Newton says registering people with disabilities can be focused in the capital city, but be lost in the rural population and can also be a vulnerable making process in itself. And I think that was a reflection to comment at our panel, one of our panelists had made, and another barrier. And then Sarah Magoba says that there are lots of myths and misconceptions related to persons with disabilities in Uganda. So thank you so much for those comments in the chat box. And thank you to our panelists today and for coming, and for our discussant, Abdul, for your thoughts and reflections, and thank you for everyone else for coming and joining us today. So the recording will be available on our website, and we hope that you take part in other activities for International Day of Persons with Disabilities. There'll be a lot going on tomorrow for sure. Thanks everyone, and enjoy the rest of your day.
Thank you.
Thank you, Rosemary.
Thank you, Rosemary.
Thank you, everyone.
Thank you all.